Hi, this is Rhonda Davis, and I will be recording this lecture for urinary and bowel elimination. I realize this is something that you guys are very familiar with, since most of you work in patient care areas, and you literally do put in Foleys or give enemas or pouch ostomy. So this will be just a brief review in case you have not done one of those activities in a while. Just to remind you, our kidneys, ureters, bladder, and urethra all function to help in urinary elimination. Remember, your kidneys are what removes the waste from your blood and urine. And you remember, ureters take the urine from the kidney to the bladder. And there the bladder holds it until we do get the urge to urinate. Just please review your anatomy if you need to brush up on that in your textbook. Remember that females have a shorter urethra, usually anywhere from like 1.5 to 2.5 inches, and males' urethras are 8 inches approximately, maybe a little more or a little bit less. And so therefore males do not get as many infections or UTIs as females. Number one, the female's urethra is much shorter, so the bacteria doesn't have to go as far. And also with females, the urethra is much closer to the rectum. So it automatically puts you at higher risk for a UTI. Just briefly review your A and P, and you know that you do have your kidneys are against the deep muscles of the back on either side of the vertebral column. And the functioning unit, of course, is the nephron. And high blood flow represents approximately 25% of the cardiac output. Your kidney is very vascular. And, of course, how much you produce has a lot of different reasons it can vary. But the normal range of urine productions is usually 1 to 2 liters per day. As you know, your kidneys are not only responsible for getting the waste out of our bodies, they are responsible for maintaining a normal red blood cell volume because they produce erythropoietin. And that is what stimulates your red blood cell production in the bone marrow. Decreased kidney function leads to decreased RBCs, which automatically leads to decreased hemoglobin. Your bladder, as you know, is a hollow muscular organ. If it's empty, it lies in the pelvic cavity behind the symphysis pubis, and the shape does change when it's filled with urine. Normal bladders can hold up to about 600 mLs, but that again also varies. Some people can't hold that much, and then some people could hold even a little bit more. Your urine is 96% water and about 4% solutes, and which are comprised, of course, as you know, your organic solutes such as your urea, ammonia, uric acid, creatinine, and then you have your inorganic solutes such as your sodium chloride, magnesium, phosphorus, and then sodium chloride. The urine is sterile, and then it moves in peristaltic waves to the bladder. The protein does not normally filter through the glomerulus, so protein in urine is called proteinuria, and that's not a normal finding. It is a sign of glomerular injury. Some of the factors that influence urinary elimination, of course, as you know, growth and development, sociocultural factors, psychological factors, personal habits, muscle tone, fluid intake, different conditions, maybe surgical procedures the person's had. Medications can definitely influence it, diagnostic exams. And another thing on here we didn't even take into dietary considerations, such as drinks with caffeine could make you go more frequently as well. Some of the common problems that a lot of our clients have is urinary retention. You may have a UTI. You may have residual urine, incontinence, and either urosepsis or sepsis. And as you know, sepsis is very, very serious in client when they get that bacteria in the bloodstream. Most of the time when people have urinary retention, it's an accumulation of urine in the bladder because the bladder is unable to completely empty. So in this particular bladder, even though we said about 600 is sort of the average, someone with retention may hold more than 1,000 mLs of urine because they tend to just hang on to a little bit in that bladder at all times. It also, now, excuse me, when you have incontinence, you certainly have, you're at much higher risk for UTIs. And of course, we do really have to watch out for nosocomial infections when we're doing a Foley catheter. So many times we tend to not pay strict attention to sterile technique. And when you have incontinence, remember, it is the loss of control over voiding, and it can be temporary or permanent. And this person may not be able to void, and then the bladder gets so full that a small amount of overflow will happen, anywhere from like 25 to 60 mLs. And the person may be incontinent of this amount, or even actually void this. And so they may need to go at least as often as 2 to 3 times an hour to try to empty their bladder. Some of the types of incontinence you can have, of course, are total, functional, stress incontinence, urge, or reflex incontinence. And the leaking from incontinence may be continuous or it may be just intermittent. This is a psychosocial issue for patients, especially if it happens at a younger age, and the patient's very embarrassed, so it has a huge impact on socialization. Your older adults may not necessarily want to go buy poise pads or buy pads and wear. You see that a lot of times with the females. They will go buy feminine napkins and wear them in their panties to keep from having an accident when they have just a small amount of urine. Your older clients may have an increased risk because they simply can't get to the bathroom fast enough. Their mobility may be impaired. These, especially in long-term care, you see this. They have, they'll need help, and let's say, everybody's busy at the moment. You can't get to that person right away within a minute or so, and then therefore the person becomes incontinent and gets embarrassed. Let's say especially if they're sitting out in the day room and needing assistance to go to the bathroom, and we can't get there in time. When you do have incontinence, you have to really look at skin protection very carefully. Some of the disorders, we've mentioned retention, the lower UTIs, and incontinence that we've covered. So just remember that E. coli is a common source of UTIs. We need to use medical and surgical asepsis whenever we're doing procedures. Remember about developmental considerations. And remember, the person may, even if they are elderly, they may be too embarrassed to ask for a pad or something for their to wear in their panties. Psychosocial, we've mentioned, self-concept, culture, sexuality influences. Cultural focus. In certain cultures, maybe perhaps Hindu and Muslim, they may use their left hand to perform unclean procedures. So if you have a Hindu or Muslim patient in there and you're providing care for them, you may want to discuss this with your patient if you are left-handed. A lot of times we don't think about these little things. As Americans, we often just assume everybody can do the way we do things over here. And sometimes we forget about other cultures. And we need to be respectful of their cultures. So if you are a left-handed nurse, you need to discuss that if you have a Hindu or Muslim patient. Because to them, the left hand is not used for anything except toileting. Some cultures, if it's a female patient, they will need a female nurse to assist them or to do, even try to do an emission assessment or put in a Foley catheter. If it's a male patient, they may request only a male nurse come to help them if they have a catheter inserted or anything. Please respect privacy. It is very embarrassing to the patient for us to walk in and somebody is sitting, has putting in a Foley or something, and they don't have the bed curtain drawn or anything. And we do want to be sure and respect privacy. As you know, the ones of you in long-term care, you have to always knock on the door to announce yourself before you go in those residents' rooms. And we need to respect that privacy also in our hospital setting. Try to knock on the door or something, or make the person aware that's inside that someone's about to come in. Some cultures may require that the spouse or something stay with them if you're having to put in a Foley catheter or something. As far as your assessment, you do want to look at their history. What is their normal pattern of urination? What are their symptoms? Is there anything affecting their urination? Ask them how often they go to the bathroom. Some people go very often and others go only maybe 3 times during an 8 or 12-hour shift, if that many. Now, some of the things you can have, some of these terms just to refresh you: nocturia, frequency, dysuria, hesitancy, polyuria, and remember your prefixes. Oliguria, which is a scant amount of urine. You may have hematuria, retention, or residual urine. Some of the things that we mentioned, there were different things that can affect urinary elimination. Of course, medicines. If you are on a diuretic, obviously, you're going to go to the bathroom more often. Certain types of medicines, such as with caffeine products, they will make the person go to the bathroom more. The activity level. What are the environmental barriers? Is this person not able to go to a bathroom? Let's say maybe for whatever reason they work in a job in an area where the bathroom is not clean. Some people literally try to hold it all day long and wait and go when they get home. Does the person have sensory restrictions? Are they have limitations such as visual, and maybe they can't see as well to get to the bathroom? Have they had any major surgeries? Have they had, and always when you ask about surgeries, a lot of times they may not remember that they had a cystoscopy, because often, even nowadays, they're doing those in the office so much. But you want to ask your client, have they had any surgeries or procedures done before? Certainly if they have a urinary diversion, if they have an ostomy, is it nephrostomy, or is it somewhere else? And remember, your nephrostomies are much more difficult to care for usually as far as pouch and all, than the urostomies. Please do not ever call your patient with a urostomy a colostomy. As you know, colostomy goes with the colon, not with the bladder. Are they able to drink fluids during the day? Or is this person that's restricting their fluids? What are their dietary patterns? And age sometimes has something to do with it also. Now, when we're looking at the urine, you definitely want to know, I know, and I think often this is one area we tend to forget about in a hospital setting a lot of times, unless it's ordered specific. You want to always assess the color, the clarity, and the odor. And remember, urine is usually more concentrated in the morning upon arising. That's usually more concentrated at that time. We've mentioned with retention and incontinence, and with enuresis, that is nocturnal enuresis. A lot of times, which nocturnal enuresis is bedwetting. Enuresis is just incontinence of urine. Now, with the, I will mention the urinary incontinence in case you've forgotten them, but functional is an involuntary, unpredictable passage of urine in the patient with an intact urinary nervous system. They have a strong urge to void and can't reach the bathroom. So it's all of a sudden they just cannot make it to the bathroom. Reflex incontinence is an involuntary loss of urine at fairly predictable times. So this person may not have the urge to void. Stress incontinence is when a patient has increased intra-abdominal pressure, and this leads to leakage of urine, or let's say if they cough or sneeze or pick something up heavy, they could have leakage or may have little dribbles. Excuse me. Total, as you know, is total uncontrolled loss of urine, which would happen perhaps even with trauma. And then urge incontinence is an involuntary passage of urine after a strong sense of urgency to void. Urge incontinence often is like if you're sitting there and you know you got to go to the bathroom really, really bad, and let's say it's not convenient. You're in the middle of a test or something, or you're maybe in a car and can't get to a bathroom soon enough. So you have involuntary passage after it just kind of hits you, all of a sudden you have to go to the bathroom. Other terms that we've mentioned so far: oliguria, dribbling, hematuria, retention, and then residual. Now, refresh in your techniques book how to do your different specimens. Remember, if we're going for a urinalysis for a client, please teach them how to do a clean catch or midstream specimen. So many times, and I've seen in the ER, a lot of times we go in and hand them the plastic cup and we hand them the little packaged towelette thing and we say, here, clean yourself, and then we walk out the door. And sometimes patients may not necessarily know what that means, so be sure and be specific that they should clean the perineum area or clean the meatus if it's a male, begin to void some, and then stop the voiding, and then collect the specimen. So that's why we're calling it midstream, because it's literally the person starts urinating and then tries to stop it or hold it, and then they put the cup under. Now, when you're looking at urine cultures, remember, you may get your preliminary usually in 24 hours, but it takes longer than that a lot of times for them to do the specific organism. So make sure you do review how to do that technique, and remember that if it is a female client and she is on her menstrual cycle, you want to make sure note that on the lab specimen. And in most cases, a lot of times where we can't get a midstream on a patient that having their menstrual cycle. Usually the doctor will say, no, go ahead and get a straight cath to be more accurate. Some of the exams, be sure and review KUBs. This is a flat plate x-ray of the abdomen, and KUB stands for the kidney, ureter, and bladder. There's no prep needed for this, and this kind of looks at the gross structures of the urinary tract. So it's kind of like a quick look picture or so. Now, an IVP is more invasive because it has you get an IV injection of radiopaque dye. And as you remember, always check for allergies to iodine or shellfish or contrast media before you send that person to X-ray for an IVP. Typically, they are NPO after NPO at midnight, and then sometimes, you know, I mean, this person, they may do a bowel prep, but you want to make sure and monitor your client with INO. A CAT scan is non-invasive. It's used to visualize the condition. Perhaps it can also pick up on tumors, obstructions, masses, or if the lymph nodes are enlarged. Ultrasound is painless. It's just really a non-invasive diagnostic tool. Cystoscopy is where they insert an instrument through the urethra to look at the interior of the bladder and the urethra. This is a lot of times done in physicians' offices now. So if it's done in a hospital, then you may have to follow your pre-op surgery orders if they're going to surgery. When they come back from having a cystoscopy, make sure you document their first voiding, and note that it may have some a slight amount of blood in it after a cystoscopy. Urodynamic testing is tests that measure and transport the elimination storage of urine. This may be done. You can have tests like this done in a physician's office, where you are literally voiding. Almost looks like a bedside commode or so. But this thing literally can measure the urine. It also can, it's very sensitive. It's hooked up to a machine, and it can tell, like, if you stop voiding and then start again, because it literally will print out a paper and it'll have the spikes in it as far as the urine strain. Renal scans are really looking at the renal blood flow. And the person will get isotopes injected for a renal scan. Angiogram, of course, is given with a contrast, and it outlines the vascular supply to the kidney. This person may, after an angiogram, they may have bed rest anywhere 4 to 8 hours. Make sure you check pulses, extremity pulses, especially on the site that was where the angiogram was inserted. Monitor those vital signs. They may have a pressure dressing on that site, so you want to observe for bleeding. Just remember that contrast or dyes can be very toxic to kidneys if the client's already dehydrated or if they have impaired renal function. Now, you're very familiar with most of these as far as assisting with normal urination. You do want to try to get the person to empty the bladder. And you're familiar with exercises, the Kegels exercises, to try to strengthen pelvic floor muscles. But even if the person does those 3 or 4 times a day, it may take months for them to really get more of that tone back. And some of the things we're looking at when we are assessing urine, of course, besides INO, is the one other thing is specific gravity. That also we may want to look at the pH. They may look at, as you know, if you get a culture back, a preliminary that says it's got a lot of epithelial cells, and more than likely that's a contaminated culture. And while it might work okay for urinalysis, it will not work for a culture, for urine culture. When some of your nursing interventions, of course, sometimes it might be the physician, especially when you see clients having difficulty voiding in lying flat on the bed. So you may have to raise the head of the bed up. For men, you may, if they're able, they may want to stand up on the side of the bed. With a routine urinalysis, it does not require a sterile specimen, so we don't have to get a cath specimen. But remember, even with a routine urinalysis, that specimen needs to get to the lab in 1 hour, or that it has to be refrigerated. For instance, a lot of times doctors will ask the patients to collect different things at home, and you tell them they have to put, if it's in the middle of the night, when they get the specimen, then they have to put it in the refrigerator till they can get it to the doctor's office. Because if that urine is left at room temperature, it will begin to grow bacteria. If you're clean voided or midstream, please remember to ask them to wipe front to back. And I know sometimes it's really hard for women, especially if you're not specific when you're asking them to wipe, like to try to really get close to the inside. Sometimes you will notice that the person just kind of does a quick wipe over, and really all they're wiping are the external labias. They're not even wiping the inside of the meatus. Also, make sure that they're told not to be touching inside the cup. If it's a male client, tell the male not to touch the cup when he is voiding into it. And just as I said, they should start the stream in the toilet. Let's say if it's a female sitting on the toilet, go ahead and start to void and then stop. Then collect the next stream. If it's a sterile specimen that you need, then usually you catheterize the client, or you can obtain it from an indwelling Foley bag. But usually the only time we can do that is if it's the first time we're putting in that Foley. It's a brand new Foley. Then yes, we can use that urine. Sometimes you may see people empty the Foley bag, and then they, as you know, those catheters sometimes have those little rubber ports where you can literally put a syringe in. But if that Foley has been in that person, let's say it's a home health patient that's come in and they've had that Foley 3 weeks now, that really is not a good way to get that sample. And I know probably most of you out there have done that, where you clamp that tube right below that port, and then you let the fresh, but just remember, if that bag has been sitting there that long, more than likely it is contaminated all the way up the tubing. If we're doing a 24-hour specimen, that is collected for 24 hours. And remember, you start it when that person goes to the bathroom. When they go in void, that's the time you begin. And if this patient forgets and goes to the bathroom and flushes it during this time and forgets to, call someone and say, here's my hat, in the Puritan hat in the toilet needs to be put in the container or whatever. If they miss it just one time within that 24 hours, you have to start that all over again. And remember, this is the brown plastic container usually we use for this, and it has a special preservative in that container. Some of your diagnosis, just to review, as far as health promotion, we want to make sure our clients are hydrated. Try to help them with their voiding habits, hygiene, they need to try to really empty the bladder completely. Always look for skin integrity. And to help prevent UTIs, some things you could teach the patient is to try to keep the urine acidic. That in the acid, the more the acid the urine is, it does help prevent the growth of microorganisms. And things such as meat, eggs, cranberry juice, whole grain breads, all help the urine to be more acidic. Now, you're familiar with catheterization, and a lot of times they may do an intermittent catheterization, but that's usually just for short-time use. Or it may be an intermittent catheterization on your quadriplegic that's at home that is self-catheterizing themselves. Now, with different lumens, as you know, there are different sizes of catheters. They can range, anywhere from 8 on up. And just remember, the smaller the number, the smaller the size of catheters. And I know a lot of times in our equipment it's the opposite. But with our catheters, a small size truly relates to a smaller size tubing. Remember about your taping for males and females. Why do we tape? We want to decrease irritation to the external genitalia. And I hope none of you that are in this class have ever seen a penis where it has literally been split because of a catheter not being taped, or the tape is up too tight or too high on the leg, and it literally could split the penis. So, and it will do the same for a female meatus. So please make sure to look at the position of those catheters, especially if you're coming on shift and maybe it was put in earlier that day. Always look at your catheter placement. Some of the tips. Biggest thing is hand washing. And remember, we're the ones who often put our patients at risk with catheters. It's our poor technique, or either we go in there and we open up that drainage system at connection points because we want to get that specimen. Or, and remember, try not to pull that catheter bag, higher than the person's bladder. We don't want the urine going back up into the bladder if it's already been down in the tube or the bag. Remember, if that tubing does become disconnected, wipe it with an antiseptic solution before you connect it. Be careful when you're emptying the Foley bags. I notice a lot of times where they hang on the bed, especially if they're large or the bed's real low, the bottom of the Foley bag may literally be laying on the bottom of the floor, and you do not want that. You don't want the Foley bag laying on the floor. And when you go to empty it to measure the urine in it and to empty the bag, you don't want that spigot or the end part touching the floor. You want to empty the urine out of the bag before PT comes to get them and maybe ambulates them down the hall. Nobody wants to carry a bag full of urine up and down the hall when they're doing exercise or when they're doing or going somewhere for a procedure or anything. So try to be cognizant of that. You want to try to empty the bag every 8 hours. I realize that most hospitals now do 12-hour shifts. So usually nowadays it's probably not getting empty but every 12 hours. You want to try to get the patient weaned off of the Foley catheter as soon as possible. And this does take a physician's order, as you know, and it will take a physician's order to DC the catheter. A condom cath, remember that this is one that you still, of course, wear gloves and you apply a condom catheter on. Be careful, look in your procedure book, because I have seen this before where they put the condom cath on and then they put the tape wrap it round and round and round the base of the penis. As you guys know, what can happen if that is too tight at the base of the penis? What if this client is a stroke patient and can't tell us that he's hurting or that it's really bothering him, and then that stays constricted for several hours? So make sure that it should be kind of like the tape of a spiral going down the shaft of the penis on that condom catheter. Do not take and put that tape all over pubic hair, because that is really cruel punishment, I think, when you go to try to take it off, to take the catheter off. Do review your procedures as far as putting in catheters, and I'm sure you may have already had check-off in lab by the time you hear this lecture. Remember to try to increase fluids unless the patient's on a fluid restriction. And so many times your elderly people say, well, I'm not going to drink much because then I'll have to be running to the bathroom and I might wet my pants. But it will cause increased UTIs if they're not getting enough fluids. In a client that is in ICU or is in PCU or something in a critical area, then I&O is usually taken every hour, not every 12 hours. If you look at urinary diversions, you may have ureterostomy, ileal conduit, you may have a cock pouch. That is something where the person doesn't have a stoma. They just go in and catheterize periodically during the day. With a straight cath, often this is, you can do this, clients that are bedridden or quadriplegics, often you see this at home where they do their own straight cath. And if it is a client in their own home setting, they usually use medical asepsis, not sterile technique. Some of them may say, I keep my catheter, and they use the actual catheter tubing more than one time. And while we would never ever think of that in the hospital, we never should, then even our home patients, they may reuse theirs for several times because that's their own pathogens they're dealing with, it's their own house, and some of them may keep them in like a bottle full of betadine or whatever, however they're disinfecting it. But they do wash and disinfect the equipment and then reuse it. Another straight cath that you see, especially if you work in the ER, are the little small specimen containers with a little stiff tip on them that you can pull out. And those are so much easier to catheterize a patient with than a Foley because they are stiff and they're tiny, so they go in very well. Just remember that you still want to follow the same sterile techniques even when you're getting a specimen. As far as bowel elimination, I think you guys are very familiar with this. As you know, your bowel is essential for our health. It rids our waste out of our body. And your feces is usually 75% water. And remember, changes in bowel habits sometimes are the reason, early signs and symptoms of an illness. With the GI tract, obviously you know this, it begins with the mouth and ends at the anal orifice. You can review your anatomy. And then, of course, the physiology or the working part of it. Remember the peristalsis, water absorption, storage, and then also secretion of mucus. Factors that are critical to function, of course, is sensory awareness of when they have to go to the bathroom and to be able to control that sphincter tone. Normal defecation is painless, But then you may have some people who really have trouble with either constipation or diarrhea. When you're looking at the stool, you certainly want to be able to document the color or consistency. We usually have to quantify it with, large or medium stool, small amount, excuse me. And you want to, are there any blood visible? And odor, a lot of times, can mean different things depending on, as you know, it could be a fatty stool, which is, foul smelling. It could be having a GI bug or something could cause the bad smell. Some of the factors that, of course, affect our elimination is the, excuse me, our age can affect it, the diet, the fluids we drink. Are we someone who sits all day and doesn't get any exercise? Stress can affect bowel. Some people get diarrhea when they get anxious or get stressed out. Medicine can certainly affect it. Personal habits. Anesthesia or surgery, as you know, it puts the gut to sleep if the patient's put to sleep. With an altered elimination, these are things like constipation, where your patient may be impacted. They may have incontinence. And please remember, especially in your long-term care patients, if that person, a lot of times we see the care assistant or CNA may come and say, well, so-and-so's having a little bit of diarrhea. And then maybe it happens again, they're having just a little bit of diarrhea. If it's liquidy stool, always remember that your person may have an impaction. And what's happened is just a small watery amount is seeping around that impaction. But unfortunately, a lot of times we don't want to deal with that little bit of watery stool. So what do? We go look at those standing orders. Oh, they may need Lomotil, or they may need Imodium or something like that. And we really cause the problem to become much, much worse, simply because we didn't do a good enough job with assessing. Some of your, of course, a diagnosis with constipation, it could be related to decreased motility. It may be due to, just slowed motility in the colon. And remember, the longer that stool stays in the colon, the more water is going to be reabsorbed out of it. And the stool will become drier. Now, when you are looking at your patient, make sure to also ask them about color if they're coming in with different problems of maybe diarrhea or constipation. Because remember, if your stool is black, if the patient says it's been black and tarry kind of, that reflects usually an upper GI bleed. If it's bright red in their stool, then they may either have a lower GI bleed or maybe have hemorrhoids. And if it is white or clay colored, they will have that means they've got an absence of bile being excreted in their stool. Excuse me. Remember, when your person is in having tests run and all, remember to always follow up with certain x-rays. For example, if the person's having barium, if they're having a barium swallow, make sure that you give them fluids, and usually you'll give them a laxative or something after, to try to get all that barium out of their system. When you're looking at different interventions, you want to try to increase the bulk. Excuse me. Sometimes we forget to try to provide privacy. We may have to use different kind of meds to help the person. And remember, sometimes it may just mean that we need to get up and have the client walk up and down the hall a little bit. Or we may need to get them, some people like apple juice or cream juice, we may need to get something like that. And then they say that if they can have that, then that may help them go too. Different medicines that we use, of course, as you're familiar with Metamucil, you may see Colace, milk of magnesia. Remember, milk of magnesia is saline and it's going to draw the water out of the colon. You may have to give your client a suppository or an enema. We mentioned impaction a while ago, and it calls from unrelieved constipation. And that feces just collects and collects and collects and becomes very hard. It can extend into the sigmoid rather than just the rectum, so it can be actually higher up. And excuse me, the client that's impacted, usually their abdomen becomes distended and firm. They may have a lot of nausea and vomiting and just feel very, very full. So I don't know how many of you have had to remove additional impaction, but it's probably one of the things that nurses fear to do more than anything else, I think, a lot of times. Because it is painful to the patient, and please remember that. You're manipulating their anus is already tender, and here we are, we're trying to dig out stool from their rectum, and it is very painful for the person. So I can't stress how important it is, you guys, to monitor your patient for their bowel habits. A lot of times we don't think that's a big deal, and we don't bother to go back and look how many days has the client been without a bowel movement. And it's not fair to send a patient home that is impacted. The opposite end, we have diarrhea, and as you know, that is increased frequency in loose stools. You want to try to correct what's causing the diarrhea, because you can really get very dehydrated if you're having a lot of diarrhea. And it can be caused by, of course, a virus, maybe just picked up a bacteria somewhere. It could be caused by certain spices, infection, stress. Crohn's disease could cause ulcerative colitis. And you want to try to replace fluids as ordered. And remember, if someone is having frequent diarrhea in the hospital, let's try to find them some of the baby wipes, because as you know, if you go 3 or 4 or 5 times, then you're looking for something softer to wipe up with. So try to be kind and remember that if your hospital carries them. One thing on here too, remember that tube feedings can cause diarrhea as well. And of course, certain medicines can cause it. If they are incontinent, this is an involuntary passage of stool and gas. And the anal sphincter, excuse me, they may not have control over it. Let's say it could be a spinal cord injury patient where they don't have control over it. So you want to make sure, the way we treat it depends on what is causing the incontinence in the first place. With gas, it could be, the abdomen can be distended. They may feel very bloated. And so with this, usually with our post-op patients, and they're saying, my stomach's just killing me, we try to get them up and walk them. So increase their mobility. If the gas is so bad, if they're just having so much distension, they may put an NG tube down. But I haven't seen a rectal tube in a while. Usually you may see one like every 4 or 5 years, it seems like, but they are still around, and you guys may have seen more than one in your practice. Gas is one of the most common GI disorders. If you think about it, how many commercials are there on TV about take Beano and you won't have gas? It's amazing how creative they've gotten with all these TV commercials about Gas X and all these kind of medicines you can do to not have gas, especially in public places. Hemorrhoids are distended veins, and they can be either internal or external. A lot of times hemorrhoids occur in pregnant women or post-delivery. They can be caused by chronic illness, obesity, by the person having to really strain to defecate, and they can treat it with different, you've probably seen the Tux pads in the round bottle. They're little soft wet sheets you can put on the anus itself. Excuse me. They may use witch hazel soaps. They may have, you've certainly heard of Preparation H or sitz baths. And usually with hemorrhoids, the person will complain of itching and burning. After someone has hemorrhoid surgery, you have to avoid constipation, and they can have severe pain with having a BM, as you know, post-surgery. And it's almost like the patient will dread having a BM so much that they may literally not have a BM when they are feeling the urge and just try to hold it down, because they know it's going to hurt them. This picture is blurry. I guess when it was blown up, it just really distorted. But you do have, all of you have probably seen an external hemorrhoid at least by now anyway. Some diversions are your ostomies. Remember, this could be temporary or permanent. And the opening is called a stoma. And usually your ostomies are located in the ileostomy or colostomy if it's in the colon. And the location of that ostomy determines on the stool consistency. Here are some different types of ostomies. You may have a loop where it's a temporary in the transverse colon, so it's going to be kind of high up on the abdomen. You may have an endostomy where the proximal end forms a stoma and the distal end is removed or either sewn closed. And your double barrel, and usually this is severed and both ends are literally brought through the abdomen. Remember, with an ileostomy, that one will drain usually liquid feces. It can't be regulated. And with ileostomies, they are more prone to have skin irritations because it has more enzymes that irritate the skin. And with an ascending, your ascending colostomy in the ascending colon will drain liquid constantly. With a transverse would be going across the abdomen. That stool would be less liquid. A descending colostomy would be on the patient's left side of the abdomen. And usually that is more solid due to more water absorption in the colon. When you're looking at the loop, you will have one stoma, and a loop of bile is brought out onto the abdomen, and it's held in place by a little bridge. Excuse me. They literally hold the loop of the colon up. They put a little plastic or glass or something. It's like it can be a rubber-coated glass rod, but mostly nowadays you just see the hard plastic kind. That sits under that colon, under that loop, until their incision heals, and then about 2 to 3 days post-op, the loop is incised and makes 2 openings into the colon. This is where you may see a loop done in emergency, especially for a gunshot wound victim or somebody's had trauma to their abdomen. With the double barrel, you have two stomas, remember? And your proximal stoma is functional and irrigated. The distal stoma is non-functional and usually just has mucus. If it's an end colostomy, you just have one stoma, and that distal end is either resected or removed or either closed off with suture. And the person could literally have a Hartmann pouch where it's just closed off. Your colostomies can be either temporary, maybe a few weeks, few months, letting that gut heal, or it can be permanent. Some alternative procedures. You can have an ileo pouch anastomosis, and this is where they literally have a pouch connected to the anus. You can have a surgical pouch built, literally. It's the continent ileostomy, and the small intestine creates a pouch, so the person has to go and empty the pouch several times a day. And then you may have a lower anterior resection that's performed for low rectal cancer. And there is, of course, the people who have ulcerative colitis, Crohn's disease, diverticulitis. They may have to go in and take those sections of the colon out. When you're pouchinostomy, and I do have a little video clip I'm going to try to get loaded, but you do not delegate that to your techs or your CNAs. You want to make sure, observe it for leakage, and observe that stoma color. It should be moist, reddish pink. And remember, at first the stomas right after surgery are going to be larger and swollen, but they do shrink. When you're putting on each pouch, you want to measure it, because often in the hospital, what happens? Someone comes and cuts a pattern or a template. I know y'all have seen this. Leaves it in the drawer. Excuse me. It may work for a day or so, but then everybody cuts it out, and a lot of times that stoma starts shrinking, and that hole is too big on that template that is cut out, and that exposes that skin around the stoma to the stool or drainage. Make sure that you change that pouch when it's a third to a half full, because the weight of that pouch being full of stool will disrupt the skin seal and cause irritation. Excuse me. Your pouch, usually cut it about a 1/6 to an 1/8 of an inch larger, the hole larger than the stoma, if it's the one that you're having to cut to size. Some of them are already pre-sized. Pouching is very important, and it sort of takes practice when you're learning how to do this. You do have to be patient, and you do really have to make sure you clean very well when you remove the old pouch, because especially if it's got that pectin, or if you had to use barrier cream, the skin barrier stuff, it may have a lot of residual that you have to clean off before you put your new pouch on, or it's not going to stick. This is just showing you a double-barreled ostomy, and you can see by all the surgery scars this person had major abdominal surgery. All of you know that your nursing interventions now, what you need to do. As far as nutritional, teach them a low residue diet. Avoid gas-forming foods such as Brussels sprouts, corn, cabbage, onions, cucumber, garlic. And excuse me, these when someone has an ostomy in their pouch, it will blow up with gas too. Just because it's got a pouch doesn't mean they do not have gas anymore. So you may have to go in and literally deflate the balloon, so to speak. You have to go in, it's blowed up, they can literally, gas can distend it like a balloon. And you have to go in there and unsnap just a little bit, especially on our two-piece systems. You just open a little bit. Be careful when you're working with ostomies not to make faces or comments or things like that, because the person is very sensitive, especially at first, about having this anyway. Remember, if they're having a lot of liquid stools, if let's say an ileostomy or something, they may need extra sodium, water, potassium. So you want to include foods in potassium that are high in potassium, such as bananas, potato, oranges, tomatoes, fish. The stoma has to be kept clean and dry. And you may want to use a deodorizer in the bag, and some of them have charcoal filters too. And you may want to use a deodorizer in the room when you're changing the bag. As far as maintenance, irrigation may take up to an hour. And the person usually irrigates to regulate the output. And they have these long sleeves, just like the ostomy bags. The person can sit on the toilet and the sleeve goes down between the legs, and as they're irrigating it, literally the water goes in the toilet. You want to position your fluid, irrigation fluid, about 12 to 18 inches above the stoma. And usually at first, now remember, you do not hang up 1,000 on this, especially first. Your very first initial irrigation, you may only want to go up to 250 cc's or less, or mLs, I should say. Remember, when we're irrigating it, they have a special stoma guard that goes on the tubing. So you don't use the tubing direct like we do with enemas. There should be a little cone-like thing that goes on, it's called a stoma guard, it goes on the end. And that way it keeps you from going in too far. As far as diagnostic tests, I'm sure all of you by now have done a guaiac, a stool. Remember, that is a screening, not a diagnostic. Hemocults, proctoscopy, proctosigmoidoscopy, and colonoscopies. Just review those in your techniques books. I'm sure you've had cared for clients with these now. And with your hemocult or your guaiac test, that's measuring microscopic amounts of blood in the feces. And a lot of times this is used as an annual screening for colon cancer for a lot of people. A false positive can be caused, however, from red meats, poultry, fish, and some raw vegetables, vitamin C, and aspirin. And people that are on anticoagulants are, as you know, are at a risk for developing GI bleed, so they should be regularly screened for hemocult. The blood in the stool will turn blue if it's positive. If the client's having a proctoscopy, that is simply the rectum. They're going in and viewing the rectum with a scope. If it is a proctosigmoidoscopy, it will be the rectum and the sigmoid colon. And then a colonoscopy means they're going all the way to the ileocecal valve usually. Review your assessment. And remember, we always look, listen, and then feel. And nurses, usually we do not tend to percuss the clients. That would be more like your advanced practice, or your nurse practitioners would be percuss. You may be taught that. It depends on what kind of floor that you work on. So you want to start like a clock. Start after you've looked at the abdomen for any bulges or scars. Start at the right lower quadrant. Move up to right upper quadrant. Just like a clock. Go over to left upper quadrant, and then left lower quadrant as you're listening. And we should hear sounds every 5 to 20 seconds or so over all 4 quads. Now, if it's hyperactive bowel sounds, it may be every 3 seconds. If it is hypoactive, you may only have hear one thing per minute. If you don't hear anything, listen for about 3 to 5 minutes before you say there are no bowel sounds. Borborygmi, sorry, I always have trouble with that. This is where you have increased bowel sounds. And you may see this as when the person has a partial obstruction of their small intestine. Palpation, remember, we don't percuss, but we can palpate, but use light touches. Don't just go in and try to press very hard on the abdomen. Get their history, what is their normal pattern, and everybody varies. Normal is very unique to each individual. What is their approximate daily fluid intake? What are their histories of surgeries that can affect the GI tract? Medicines, are they on anticholinergics that could cause constipation? And always remember about cultural considerations when you're asking these questions. So many times, you've seen it, I'm sure, nurses go in and start asking these very personal questions while the preacher's in there talking to the person. Well, we need to be respectful. And I realize we're on a time constraint trying to get our admission in, so you may have to ask the person, do they mind stepping outside while you're asking things about bowel habits and all. So, remember, a lot of cultures may consider bowel and urinary secretions are not appropriate for public display. So they would not want, if it's a male, would not want a urinal hanging on his bed rail that's full of urine. And please don't let your patients put that urinal or bedpan on their bedside table. I know you guys have seen that, and that is just awful. Our medicines, of course, you have your cathartics or your laxatives. They can be different things like Metamucil, milk of magnesia, Colace, castor oil, cascara, Dulcolax. And your patient can literally become abusive of some of these laxatives, especially with your older population. Soften, if the stool is needing to soften, you may have an order to give a suppository to a patient. But when you're doing a suppository, remember, you have to insert it beyond the sphincter. And they usually work within 30 minutes or so. Enemas, I'm sure all of you by now have given an enema. And we can use enemas either to cleanse the colon for test or surgery, treat constipation, to stimulate peristalsis. And cleansing, which is a tap water enema, is very dangerous with your CHF patients and children because it's hypotonic. If it's soap suds enema, that acts as an irritant, and you put about 5 to 30 mLs of soap in 1,000 mLs of water. Saline enemas act like irritants. Hypertonic draws fluid from circulation into the colon. These are things like your fleets enemas. They're hypertonic. You may see an oil retention enema with mineral oil, 3 to 4 ounces, especially if they're having if there's a lot of dry feces in there, so they're trying to lubricate it. And anytime you give a retention enema or an oil enema, you need to follow it with a cleansing enema later. Excuse me. If it is carminative enema, then that is to help remove flatus. You may give an enema even to try to cool down for a fever. And of course, some medicines are given as enemas. Remember about K-exolate that you give to try to remove potassium when the potassium's too high. The person is always placed on left side unless something prevents that with them physically. The container is 12 to 18 inches above the hips. If it says high enema, you may see that written, especially by some of your older physicians. That's given at 18 inches above the hips. If the person complains of cramping, try to lower your bag and clamp the tube if they're cramping. And try to wait just a few seconds and you make them restart. Make sure you chart your results from the enema, and the amount of solution should be, for children, usually you do 500 mL or less. The smaller the child, the less you use. Obviously, if it's an infant, you would use 250 mL or less. With adults, they can, usually you may see 750 mL or up to 1,000 given. When you're doing a stool specimen, you do have to if it's a liquid stool, you need about 15 to 30 mL of liquid stool. Make sure you get it to the lab immediately. Now, you certainly know what an enema is. Just remember that a cleansing enema will act by stimulating peristalsis because it's infusing usually normal saline or either tap water. It doesn't have to be sterile for an enema. And in children, you would use, in infants, and usually small children too, you only use usually normal saline cleansing enemas because you don't want to alter the fluid electrolytes. I think you know the positions. Normal saline or isotonic is the safest solution to use. Make sure you know what your policies is in your facility about digital removal of stool or removing an impaction. You certainly want to assess the client for comfort and get your supplies and review the procedure if you've never done this before. When you're looking at specimen collection, just as a review, remember you could do a midstream, you could do a sterile. The 24-hour urine collection, you have to keep it in like a basin with ice in it, so you keep it on ice. Stool, they may do specimens to check for blood or check for parasites. And make sure you always document that you collected that specimen. This just reviews some of the diagnoses that you may see with elimination. And if you have any questions, please feel free to email me. I forget to check in within the inside of Blackboard though, so try to just email my Southern Union, which would be rdavis@suscc.edu. Thank you guys. I hope this was not too boring for you, because I'm sure you're very familiar with these two topics.